Hello, my name is Dr. Michael Mack. I'm one of the ophthalmology residents here at the University of Calgary, and I'm also joined by Dr. Collier Jang and Dr. William Trask. Together, we are the resident team who is going to be teaching you today about a diagnostic approach to pupil disorders. We do not have any conflicts of interest or any financial disclosures. We will try our best to use images that are labeled for reuse, and we will reference sources where you can look at for further information. Now, I know, even as a medical student, that this stuff is really hard to understand. I remember struggling a lot with neuroanatomy and neurophysiology when I was in medical school at the University of Toronto. I think my best lesson came from a resident at the time who taught me not to get lost in the weeds and instead try to focus on understanding the pathways and reasoning behind why things work, and the clinical scenarios will get easier, and then you'll retain this more as well. So repetition is key. I really encourage you to try to look at other resources after this talk to see if they can explain things again to you in a different way, and that will help you to memorize the pathways a little bit easier. So I really encourage you to either watch this video again or try to look at other resources as well that may help with your understanding. Let's start from the very beginning. The pupil is the center of the iris that allows light to strike the retina. However, it is also the entrance of an information pathway called the pupillary light response. I apologize in advance for this particular poor drawing of mine. I was trying to use Sidecar and my iPad to draw some of these diagrams. Now, let me take your attention to the right eye and the left eye, where light is entering, in this particular diagram, the left eye. The left, the light enters the pupil in the left eye, and then it strikes the retina, where it strikes the nasal retinal fibers, and there is also the temporal retinal fibers. The information is then transferred from the nasal retinal fibers and the temporal retinal fibers into the optic nerve, and it enters the optic chiasm, where the optic chiasm is the part of the brain where the optic nerves cross. Now, the nasal retinal fibers cross to the contralateral or opposite side optic tract. And the optic tract is just a part of the visual system in the brain. The way I think about it is that it's a continuation of the optic nerve that relays information from the optic chiasm where we were just were. And you can think about it just as a continuation of a highway of information. The temporal retinal fibers stay in the ipsilateral or same side optic tract. So the fibers from the optic tract project and synapse at the pretectal nucleus, which lives in the dorsal midbrain. The pretectal nucleus is a part of the circuit that mediates the pupillary light reflex, and that's all you need to know about the pretectal nucleus so far. Now, this is where something really interesting happens. First of all, I have to introduce you to these two red circles in the center of the midbrain, which is my diagrammatic representation of the Eddingford-Westphal nucleus. The Eddingford-Westphal nucleus is the accessory parasympathetic cranial nerve nucleus of the ocular motor nerve, which later on will supply the constricting muscles of the iris. And we're not really there yet, so just hold that thought on what it does for now. What is really important is that the right side pretectal nucleus actually forms connections with both the right side Eddingford-Westphal nucleus and the left side Eddingford-Westphal nucleus. This is through a connection called the posterior commissure. Now, the left pretectal nucleus also does the same thing. It connects to the right Eddingford-Westphal nucleus and the left Eddingford-Westphal nucleus. So let's stop right now and let's review. Firstly, light enters the eye via the pupil. The light hits the retina and is converted into a signal, and that signal transmission goes through the optic nerve, where there is signal from the nasal fibers of the retina and the temporal fibers of the retina. At the chiasm, the nasal fibers cross to the contralateral optic tract, where the temporal fibers stay on the same side of the ipsilateral optic tract. The fibers then synapse in the pretectal nuclei in the dorsal midbrain in the collicular region. Now, the pretectal nuclei does a funny thing and actually projects to both the ipsilateral and contralateral Eddingford-Westphal nucleus via the posterior commissure. And it does that for both pretectal nuclei. And what you've covered just now is what we call the afferent pathway of the pupillary light reflex. Now, the Eddingford-Westphal nucleus, where we left off, projects fibers that are parasympathetic and preganglionic. So if we follow the left Eddingford-Westphal nucleus and follow its fibers, it exits the midbrain and it runs along the third cranial nerve. So the fibers that we were just talking about that is running along the third cranial nerve synapse in the ciliary ganglion. The ciliary ganglion is a bundle of parasympathetic ganglion. So the postganglionic fibers from the ciliary ganglion go into the eye and innervate the pupillary sphincter, resulting in constriction of the pupil. If you think about other sphincters in the body, what it does is it tightens and then it closes the aperture. So let's stop and review the efferent pathway. So after the Eddingford-Westphal nucleus, there are parasympathetic preganglionic fibers that exit the midbrain and travel along the ocular motor nerve, otherwise known as the third cranial nerve, and then synapse on the ciliary ganglion. The fibers that leave the ciliary ganglion are parasympathetic postganglionic fibers that innervate the sphincter muscle of the pupils, resulting in pupillary constriction. So starting from the afferent pathway to the efferent pathway, we have now covered how the pupil constricts when light is shone into the eye. So let's look at this one more time. Light enters the pupil, goes into the eye, and hits the retina. The light hits both the nasal and temporal retina. Information from both the nasal and temporal retina go into the optic nerve. Information from the nasal retina crosses over the optic chiasm into the contralateral or right side optic tract. The temporal fibers stay on the same side, and then they also enter their respective optic tract. Both connections enter the right and left pretectal nucleus. Now, this is where, again, something really interesting happens. The right pretectal nucleus connects with both the right and left Eddingford-Westphal nucleus. The left pretectal nucleus connects with both the right and left Eddingford-Westphal nucleus. The information from the Eddingford-Westphal nucleus exits, follows the third cranial nerve, and then it synapses with the ciliary ganglion. The ciliary ganglion then projects fibers that are parasympathetic in nature to the sphincter of the pupil, causing it to constrict. Now, one thing about this whole diagram I want you to think about is that when light enters the pupillary pathway, it synapses with both Eddingford-Westphal nuclei, which means that even if you only have light entering one eye, both eyes receive a parasympathetic input from that particular interaction or light entering that left eye. And so the input from one optic nerve crosses to both pretectal nuclei, which projects to both Eddingford-Westphal nuclei, and both Eddingford-Westphal nuclei project to both pupils in the efferent pathway. This is why shining a light in one eye will cause both pupils to constrict. Let's take a short break here and just look at this quick little meme. So let's say I damage the right optic nerve. So when I shine a light to the left eye, what happens to the pupils? So let's look at this in more detail. What happens to the left optic nerve is exactly what we covered in just the previous slides. Because this pathway is intact, the light enters into the eye, goes to the optic nerve, goes to the pretectal nuclei, innervates both Eddingford-Westphal nuclei, which innervate both eyes. So that pupillary parasympathetic control is intact from the left eye. So if you shine a light into the left eye, both eyes constrict, even though the right optic nerve is damaged, because remember what I said earlier, you only need input from one eye to control the pupillary constriction for both eyes. Now, what happens if I shine a light in the right eye? Well, there's damage. So if let's say that there's limited signal to the right eye, so the right eye says, hey, there's not much to no light at all. There's very little signal that goes to the optic nerve, goes to the pretectal nuclei. There's very limited signal that goes to both Eddingford-Westphal nuclei, which goes to the ciliary ganglion, which innervates both pupils. And I want to emphasize again that there is no parasympathetic signal to both eyes. And remember, the parasympathetic system is responsible for constricting the pupil. Constricting the pupil. Sorry, my recording broke off there a little bit. So the pupil paradoxically dilates in both eyes. By not being able to relay the intensity of the light as accurately as the healthy pupil on the left side, the diseased side or the injured side causes the visual pathway to mistakenly respond to the decrease in stimulation as if the light itself were less bright. So what happens then is that because there's less signal, the pupil will paradoxically dilate in both eyes. We say paradoxically because the light is the same intensity as I just entered into the left side. So what happens if I swing it back to the left eye? Well, it's the same answer as before. The pupil will constrict for both eyes. So this is called the relative afferent pupillary defect, or an RAPD. Let's look at the example that I put up there. In the dark, both eyes are dilated. When I shine a light into the right eye, both eyes constrict. Then we know that the pupillary pathway in that eye is intact. However, when I shine it to the left eye, there's something wrong. Both eyes dilate. So we know that there is less signal entering the left eye. When I shine it back to the right eye, the pupils constrict once again. So from this example, we know that there is a left relative afferent pupillary defect. Now, a theoretical example is that let's say I injured both nerves, the same severity, so 90% of the nerve is damaged. There will be no relative afferent pupillary defect because it is relative to the other nerve. So if I shine a light into the right eye, both pupils may not react or constrict very well. If I shine it into the left eye, the same thing will happen because there is an injury of equal severity to both optic nerves. Now, the relative afferent pupillary defect is very helpful in identifying optic nerve or severe retinal damage. So I know that there are smart people out there, and they ask me, Mike, that's just the pupillary pathway. So how does the pupil dilate? So just to review, the sympathetic nervous system is to stimulate the fight or flight response. So we know that the pupil dilates when there is a sympathetic input. But how does this input work? Now, again, I apologize for the poor and crude drawings, but there is a 3-neuron pathway for this sympathetic control. It starts off in the hypothalamus, which helps to control the sympathetic system. That's represented by that dot in the brain. It descends caudally to the spinal cord, or the ciliospinal center of Budge, and approximately areas from C8 to T2. Now, the second order neuron, or the preganglionic neuron, first exits the spinal cord and passes the lung apex, and that's an important anatomical landmark that will show up later. It then synapses in the superior cervical ganglion. Now, the third order neuron, or the postganglionic neuron, is the most complicated. So let's go through it slowly. First, the postganglionic neuron, starting from where we just left off, enters the cranium with the adventitia of the internal carotid artery. Again, really important anatomical landmark because some pathology can affect this particular pathway here. It exits the cavernous sinus with the trigeminal ganglion and the sixth cranial nerve. And then as it exits and it enters the eye, it follows the long ciliary nerve and innervates the dilator muscles of the iris. But it also innervates two eyelid muscles. The first is it innervates Mueller's muscle, which is in the upper eyelid, and it also innervates the lower eyelid retractors. So that you can read my terrible writing, I've typed it out here. Just to review again, there's a first order neuron, which is the central neuron. There's a second order neuron, which is the preganglionic neuron, in which the lung apex is an important anatomical landmark. And there's a third order neuron, or postganglionic neuron, that it also has an important landmark in terms of the internal carotid artery. So going through the third order neuron one more time, the postganglionic neuron enters the cranium with the internal carotid artery. Here, the oculosympathetic fibers exits the internal carotid artery close to the trigeminal ganglion and the sixth cranial nerve. Then it joins the first division of the trigeminal nerve to enter the orbit, where the long ciliary nerve innervates the dilator muscles of the iris and the smooth muscles in the upper lid, or Mueller's muscle, as well as the inferior retractors of the lower lid. So here's a diagram that is much better than mine, but you can use this as an abbreviated pathway onto the oculosympathetic system. So the first order neuron descends caudally from the hypothalamus to the first synapse in the cervical spinal cord, C8 to T2, also called the ciliospinal center of Budge. The descending sympathetic tract is also in close proximity to other tracts and nuclei in the brainstem. The second order preganglionic neuron is destined for the head and neck. It exits the spinal cord and travels in the cervical sympathetic chain through the brachial plexus, over the pulmonary apex, again, important landmark, and synapses in the superior cervical ganglion. The superior cervical ganglion is located near the angle of the mandible and the bifurcation of the common carotid artery. The third order neuron for the orbit then enters the cranium with the adventitia of the internal carotid artery, again important landmark, into the cavernous sinus. Here, the oculosympathetic fibers exit the internal carotid artery, and in close proximity to the sixth cranial nerve and the trigeminal ganglion, join the first division of the trigeminal nerve and enters the orbit. There are fibers then that innervate the dilator muscles of the iris and the smooth muscle in the upper lid, also known as Mueller's muscle, and then the lower lid as well, which is the inferior retractors. And if that wasn't enough, I wanted to highlight that from this particular oculosympathetic chain, there also are sympathetic fibers to the face that exit the superior cervical ganglion and ascend to the external carotid artery. So let's take a pause here and then just digest what we've just learned. Now, it's really important to know the oculosympathetic pathway in regards to pathology in relation to Horner's syndrome, which is why I'm highlighting some of those anatomical landmarks. Now let's shift gears into something a little bit more clinically relevant. Anisocoria is a description of unequal pupil size. We get this consult quite often, as well as our neurology colleagues, so a thorough clinical evaluation is important for appropriate diagnosis. Anisocoria can be lethal, so you do need to take note in terms of knowing this for your clinical rotation. So let's get one thing straight. In bright lights, what happens to the pupil? The pupil constricts. And why does it constrict? It's because of the pupillary pathway that we just covered, as well as the parasympathetic system, which is part of the pupillary pathway. In a dark room, what happens to our pupils? Well, then our pupils dilate because of the sympathetic system as part of the oculosympathetic pathway that we just covered. You think about it, it's quite amazing that all of these neuronal connections and all of these reflexes can happen so quickly. But you might be asking, well, who cares? Light, dark, whatever. So anisocoria, or a pupillary difference that's greater in the dark, suggests a lesion in the sympathetic pathway, where the result is an abnormal pupil that is smaller or unable to dilate in response to the removal of a light stimulus. So you think about it, in the dark, if the difference in pupil size is much larger, you know that the smaller pupil is the one that has a problem, and you know that it's usually a sympathetic pathway problem. So flipping on it, anisocoria, or a difference in pupillary size that's greater in the light, suggests a lesion in the parasympathetic pathway, which results in an abnormal pupil that is unable to constrict in response to introduction of a bright stimulus. So what happens normally when you shine a bright light into someone's eye? The pupil should constrict. And why does it constrict? It's because of the parasympathetic pathway. So you know that if the anisocoria is greater in the light, the eye or the pupil that is larger and unable to constrict is the pupil that is has pathology, or the side that has pathology, and it's an issue with the parasympathetic pathway. So a simple approach in clinic or on exams is that if the anisocoria is greater in the dark, the smaller pupil is at fault because it's a dilation issue with the sympathetic fibers. If it's greater in the light, it's a constriction issue. The larger pupil is at fault, which is an issue with the parasympathetic system. So the pathology or the conditions that we want to cover today is physiologic anisocoria, a Horner syndrome, and then also when anisocoria is greater in the light, there is a cranial nerve 3 palsy or ocular motor palsy, an 80s pupil, possibly pharmacologic dilation, or traumatic iris damage. So let's start off with the easiest one, physiologic anisocoria. In some people, there is a normal variant where the pupil size in both the light and in the dark are the same. So classically, if there is less than a millimeter of difference between both pupils, there is physiologic anisocoria if the difference is the same in both the light and the dark. In some cases, it can be slightly more pronounced in the dark, but that difference should still be below 1 millimeter. The other thing to worry about when anisocoria is greater in the dark is a Horner syndrome. So what is a Horner syndrome? A Horner syndrome is a sympathetic lesion, and it has a triad of ptosis, anhidrosis, and meiosis. Or Pam. If you guys watch Archer, you know that this is one of the characters that helps me remember about. So you have to understand why there is ptosis, anhidrosis, and meiosis in Horner syndrome. So let's start off with the anhidrosis part. Pseudomotor or sweat gland stimulation comes out of the superior cervical ganglion, which if you remember is part of the second/third order pathway. So if you don't have sympathetic innervation, you have anhidrosis or a loss of ability to sweat. Why do we have ptosis? So normally you have some retraction or lifting of the upper lid via Mueller's muscle through the sympathetic system. So if you take the sympathetic system away, you do not have enough innervation to Mueller's muscle, which causes it to drop. And that's why you get a ptosis or a droopy eyelid. Finally, why do we get the meiosis? Remember that the long ciliary nerve controls the pupil dilator. So a loss of the dilator muscle or a loss of the signal, the sympathetic signal to the dilator muscle causes unparalleled parasympathetic innervation. And if you remember, the parasympathetic innervation controls the pupillary sphincter, then the pupil simply constricts. So that's why you get ptosis, anhidrosis, and meiosis. So let's talk about causes of Horner's syndrome. This can be divided into different orders as well as pediatric Horners. First, let's talk about the first order or central Horner syndrome. So this localizes, if you think back to my diagram, to the thalamus, the brainstem, and the spinal cord. So things like stroke, demyelination, or neoplasms can cause a first order Horners. The preganglionic or second order Horners localizes to the thoracic outlet, the mediastinum, or the pulmonary apex. So things like a tumor, specifically something called a Pancoast tumor, which is localized to the pulmonary apex, can cause a Horner's syndrome. Things like thyroid tumors, trauma to the thoracic spinal cord, or surgical procedures such as radical neck dissection, jugular vein or vein cannulation, or chest tube placement can also cause a second order Horners. And finally, the postganglionic or third order Horners localizes the superior cervical ganglion, the internal carotid artery, or the skull base. So a dissection of the internal carotid artery, trauma, or lesions of the sellar and parasellar region can cause a postganglionic Horners. In children, things you have to think about is birth trauma, neck trauma, or neuroblastoma. So how do we work up a Horner's? So you have to remember that, like we did in the diagram, the sympathetics run along the carotid circulation, particularly in my diagram where the sympathetic fibers run along the internal carotid artery. So the Horner's may be the first sign of a carotid dissection. Let's say you have a patient that's post motor vehicle accident in your emergency department, and they're complaining of neck pain, temple pain, or even pain in the head. And you notice that one of their pupils is a different size. And then you remembered this lecture and you check their pupils in both the dark and the light, and you notice that the difference in pupil size is more pronounced in the dark. So you know that the pupil that is smaller is the one that is affected, and you're most worried about a Horner's. So you would have to CTA or CT angiography their head and neck to not miss this particular dissection. The other thing, let's say that you have a similar situation where a patient presents to your family medicine clinic with someone noticing that his pupil is of different sizes. And then you examine them in both the light and the dark, and you are worried about a Horner's. You may want to make sure that you image their chest for an apical lung mass or Pancoast tumor, because that can also cause a Horner's as well. So a congenital Horner's is the same triad of ptosis, anhidrosis, and meiosis, but there's also the element of heterochromia. The reason why is that the iris that is lighter colored, so in this uh, young boy, the left eye, there is a deficiency in sympathetic activity which interferes with the melanin pigmentation of melanocytes in the stroma of the iris. So patients with a congenital Horner's that occurs before the age of 2 oftentimes have this heterochromia or difference in iris color. The iris of the affected eye is usually lighter in color, and you have to continue to think about things like we talked about, such as birth trauma, resulting in a brachial plexus injury, or possibly a thoracic and cervical neuroblastoma. Now, this is something that is tested often as well. So we used to use cocaine to test for Horner's. When we put cocaine inside both eyes, 10%, normally what would you think would happen? Well, both pupils would dilate. When there's 10% cocaine instillation in a patient who has Horner's, with the Horner's on the right side, the pupil actually doesn't dilate as much as the normal pupil. Why does this happen? So the cocaine test, remember that postganglionic neurons release norepinephrine in the sympathetic system, similar to that in the oculosympathetic system. Cocaine blocks the reuptake of norepinephrine released in the neuromuscular junctions of the iris dilator muscle. So, if you increase the amount of norepinephrine available, you stimulate more dilation. Following instillation of cocaine in the normal eye, like we just talked about, the cocaine blocks reuptake of norepinephrine, and then the pupil will dilate. However, in a Horner syndrome, the pupil dilates quite poorly because there's little or no epinephrine already released in the sympathetic cleft. So in this particular pathway for the Horner side, there is limited sympathetic
Switching gears, we're now going to talk about anisocoria that's greater in light. In these cases, the bigger pupil is a problem and it is unable to constrict well in light, as you can see in this image where the patient's right pupil is larger with dim light and remains dilated with a bright light. The first thing we should do to determine the cause of this greater in light anisocoria is take a medical history. Ask the patient if they've had any dilating eye drops placed in one eye. It can save the patient a lot of workups, such as brain imaging, if we are able to identify a pharmacological cause of their mydriasis. Drops such as tropicamide or atropine, which are anticholinergic, or phenylephrine, which is adrenergic, can result in pupil dilation for hours to even days. Ask the patient if anyone has placed eye drops from a red-capped bottle in their eye. The list of pharmacological agents and substances that can contribute to a dilated pupil is very long. Some examples to think about on your history taking include contact with scopolamine patches for motion sickness, glycopyrrolate cream for hyperhidrosis or excessive sweating, pseudoephedrine found in decongestants, or other substances such as cocaine or Botox. Identifying these causes can save the patient and healthcare provider a lot of trouble and rule out some of the more dangerous causes of anisocoria that is greater in light, which we will soon discuss. For example, when the iris is damaged by trauma, an injury to the constrictor pupillae muscle or a defect in the iris itself will cause the pupil to appear larger. Another condition to be aware of is uveitis, which is an inflammation of the uveal tissue of the eye, which includes the iris and ciliary body. Inflammation from uveitis can cause a dilated appearance of the pupil because the iris gets attached to the anterior part of the lens, resulting in a fixed pupil that does not restrict properly to light. A cranial nerve 3 palsy can also cause pupil dilation. As a review, the cranial nerve 3 has a motor component consisting of the levator palpebrae superioris, which raises the upper lid, and the superior rectus, inferior rectus, medial rectus, and inferior oblique, which move the eyeball. Cranial nerve 3 also contains parasympathetic fibers, which innervate the sphincter pupillae, resulting in pupil constriction, as well as the ciliary muscles, which help in accommodation by causing the lens to become more spherical. When cranial nerve 3 is injured, and there can be several locations where this injury can happen, as we discussed earlier in the pupillary pathway, it can result in a characteristic appearance of ptosis due to loss of the levator palpebrae superioris function, a down and out appearing eye on the ipsilateral side due to the remaining actions of cranial nerve 4, which intorts, depresses, and abducts the eye, and cranial nerve 6, which abducts the eye, and finally pupil dilation due to the loss of sphincter pupillae function. One key takeaway from cranial nerve 3 palsies is that you must order an urgent CT angiogram or MR angiogram for all third nerve palsies. Because the parasympathetic fibers run along the outside of cranial nerve 3, it is susceptible to compression by a tumor or vascular aneurysm. Therefore, imaging with a CTA or MRA should always be ordered to rule out a compressive aneurysm, as that is a life-threatening pathology if missed. Besides compressive lesions such as aneurysms, there are many things that can cause a third nerve palsy. These include vascular ischemia, trauma, intracranial neoplasms or hemorrhage, congenital third nerve palsy, or idiopathic third nerve palsy. Vascular ischemia is actually the most common cause of a third nerve palsy, but it is important to know that these patients usually have a normal pupil function due to the arrangement of the parasympathetic fibers more peripherally in the third cranial nerve. This peripheral arrangement allows easier blood access from peripheral vessels. One final thing to talk about when considering anisocoria that is worse in light is Adie's pupil. This condition is usually seen in females around the third to fourth decade of life. Adie's pupil presents as a pupil that remains consistently dilated and does not constrict much to light. An interesting feature about Adie's pupil is that this pupil does constrict well when looking at near objects for accommodation, as seen in the bottom image. This is because Adie's pupil is caused by damage to the ciliary ganglion. We can do a test for Addis pupil by using dilute 0.1% pilocarpine in both eyes. In this condition, the affected people actually become super sensitive to the cholinergic effects of pilocarpine and constricts more than the normal people. You get a reversal of anisocoria, where the people that was initially larger becomes smaller than the normal people. That covers the basic algorithm for anisocoria. The first step is to evaluate the pupils in darkness and in light. An isochoria that is more pronounced than dark can be physiologic if the two pupils are within 1 millimeter diameter of each other in size. Another cause is Horner's syndrome with the classic ptosis, meiosis, anhidrosis picture. All acute Horner syndromes need to be evaluated by an acute CT angiogram of the head and neck. For an isochoria that is greater in light, consider pharmacologic or other substance-induced mydriasis by taking a thorough history. Trauma and inflammation can also cause the pupil to appear more dilated. If the eye has ptosis, a down and out positioning of the eye, and dilation, consider a third nerve palsy and always order a CTA or MRA. Finally, consider Addis pupil for eyes that do not constrict well to light, but do constrict well to accommodation. That brings us to the end of the lecture. Overall, the main takeaway points are to be able to review and understand the pupillary pathway and oculosympathetic pathway, understand the consensual response in RAPD, understand why you need to look at pupils in the light and in the dark, understand the pathophysiology of a third nerve palsy with pupillary abnormalities, Addy's tonic pupil and Horner syndrome, and be cognizant of ophthalmologic conditions that can lead to pupillary abnormalities.